So it is to enter the YouTube live.
Okay.
Okay, so I will start.
Okay.
So good evening, guys, or good morning, wherever you are. So now we will going to have the IADS virtual webinars about how to treat endoperio lesion. And our next guest, you may recognize from our endoperio. He is Dr. Filmico. Dr. Filmico has been a protagonist and a bridge of connection for us and several dental endoperio chat. It is only fitting that we have him among us today on the spotlight. Dr. The dental department of Tokyo Dental, and in 2009 he became the director of One Love Dental Clinic in Yokosuka, Japan. He has completed several training, such as an implant training in the University of Gothenburg, Sweden 2011, a periodontal and implant training course in Endo-Perio, Arizona in 2013, an implant training course in Zurich University in 2014, evidence-based periodontology and implantology course in Japan, and Tangram Regeneration training course in France. Dr. Fumihiko is member of the Japanese Academy of Clinical Periodontology, member of the Japanese Society of Periodontology, and member of the Japan Endodontic Association. Currently, he is also Chief Director of One Love Dental Clinic and All Smile Dental Clinic in Japan. And in 2017, Dr. Fumihiko published How to Treat Endoperio Lesion, the plus by interaction. And today, he lab. So without further ado, Dr. Fumihiko.
Thanks for that. Yeah, introducing me. And at first, thanks for inviting me to be here. And I'm very privileged to be here and speak with you guys. So I'm gonna start and share my screen. Okay, can you see? Okay. Okay. Yeah, I'm gonna start. So today my topic is how to treat endoperio lesion for IADS webinar. And a little bit I'm gonna introduce myself. And I graduated from Tokyo Medical and Dental University in 2002. So this university is in Tokyo. And I opened one lab dental clinic in Yokosuka in Kanagawa Prefecture, Japan, 2009. So this is our concept one lab. And All Smile Dental Clinic in Yokosuka as well in 2016. So this is my staff. And now we are very difficult time about the COVID-19. And I started this web program and the Bureau chat with IADS recently. And each time I invited guests, great clinician from all over the world, and let them introduce their hometown and practice, and let them show their case, and had a great discussion. So this program is a month-free program. So please check and watch it. Okay, and also I published Endo-Perio textbook in Japan a couple of years ago. Unfortunately, this is only a Japanese version. And so today I'm gonna speak and share with some cases these kind of Endo-Perio case. So daily practice, we can meet these kind of very difficult cases. And if we see these cases, you may think about how is the solution of these cases and how do you treat these kind of complex cases. So today, learning object is the definition of endoperio and the history of endoperio and curing rate of endoperio and classification of endoperio and strategy of endoperio. Okay, so we're going to get down the cases. The first case is a male 41 years old, and the chief complaint was pain and swelling in the lower right jaw, and the dental history had a periodontal treatment till 2 years ago, and the medical history nothing particular. And this is a photo, and you can see the long temporary bridge about upper jaw, and about lower anterior tooth, there was some fix by resin, and lower right, there used to be some sprint fixing, but it's broken. And this is a panoramic X-ray. So today we focus on upper left canine and the upper right, first molar, and the lower left, this canine. Okay. And this is closest view. And this is lower right, this one. And this is upper left canine, and the lower left canine here. Okay. And this is X-ray. And about upper left canine, there was 8 to 10 millimeter deep pocket at the distal side, and the mobility was class 2. And about lower right molar, there was a very deep pocket, about 11 millimeters. And the lower left canine, there was a 9 millimeter deep pocket as well. So one question is this caused by endo or perio? It is very difficult question. So we check the definition of endoperio disease. So what is endoperio? Endoperio region is known as endo and the perio region are spreading each other's area. And the disorder of the periodontium may be affecting through the lateral canal and apex. And the disorder of the pulp may be affecting through the lateral canal, foramen, and apex. The history of the endoperio. The old papers say the effect of the pulp disease from periodontium. So this is first reported in 1918 by Turner and Drew. And he said periodontium with pus causes the effect on pulp such as fibrosis and calcification. And in 1963, about 85 extracted teeth cause of the periodontal disease. Seltzer found 94% of them had a degeneration of the pulp, such as atrophy and necrosis. It is like this pulp effect of 85 extracted teeth. So most of them was seen in calcification, degeneration of the pulp. And the similar result was reported by Sinai and Sultanov in 1973, Sharp in 1977. However, the other researchers denied in this theory. Bergen-Holtz and Hatter reported the study of the white rat. 75 teeth involved periodontal disease had no damage of the pulp. This is a very controversial result. And Langland in 1974 reported in their study, in periodontally involved extracted human teeth, calcification is the most observed frequently. So this is, I think, observed in clinically as well. And Langland in 1974 reported in this study as well. As long as the main canal have not been affected, pulp as a whole keeps vital. And this is a very strong message. So I'm gonna refrain. And the next curing rate of the endoperio region. So this is a systematic review by Schmidt, treatment of the periodontal endodontic lesion. A total of 1,087 titles analyzed in 111 teeth. So the result is like this. So from the baseline to 6 months to 11 months, the mean pocket depth decreasing was 4.09 millimeter and 2.31 millimeter. Sorry, this is not aggregated average, but a very simple average. But one message tooth loss rate was sorry.
Is it okay?
Can you see the screen?
No,
No.
it's all black.
Oh, okay, okay. Sorry. Once again. Oh, I lost. So. Sorry, I'm gonna start over. Okay.
Oh yeah.
Can you see it? Oh yes.
Yes. Yes.
Okay.
Perfect. Okay.
Okay. So tooth loss rate between 0 to 27%. So tooth loss rate was between 0 to 27%. It means, in other words, there might be a chance of preserving the tooth between 73 to 100%. So this is a very strong message from this systematic review, I think. And next, classification of the endoperio. So this is a very famous Simon's classification. So they divided the 3 groups of the endoperio region. The first one is primary endodontic lesion. So primary endodontic lesion is caused by a cavity, restorative procedures, traumatic injuries, and the inflammation, the first occurred in endo, and going through the foramen or lateral canals, and beyond the apex, and go up to the periodontal pocket. And sometimes, if the inflammation occurs this interarticular area, it is very difficult to distinguish from the periodontal furcation, class 2 or class 3 disease. And the process of first endodontic inflammation is involving the periodontal pocket is called a primary endodontic lesion with secondary periodontal involvement. And the next one is primary periodontal lesion. As you know, periodontal disease is started with accumulated plaque and calculus, and the inflammation go down and go through the dental tuberous and lateral canals, and sometimes this is like retrograde pulpitis, the patient suffering the acute pain. And this procedure is what we call primary periodontal lesions with secondary endodontic involvement. And the last one is true combined lesion. So true combined lesion is first, there was a separate inflammation or region in the endo and the perio. But at one time, these inflammation merged and got together. And once these inflammation merged, it is very difficult from distinguish. So which is the causes, endo or perio, like chicken and legs relationship, as you know. So let's go back to the cases. So about upper left canine. So first we checked the vitality test, and the result was minus. So diagnosis is paropnecrosis and asymptomatic apical periodontitis. So we did endodontic treatment, 3 sessions, and this is root canal filling. And 1 year later, the pocket was recovered like this, 8 to 4 millimeters, only by endodontic treatment. And about a lower right molar, there was a 11 millimeter deep pocket. Vitality test was a minus as well. So diagnosis is necrosis as well, asymptomatic apical periodontitis. So we did 4 times endodontic sessions and filling like this. And this is the result, 1 year. We waited for 1 year, but this tooth, there was still a deep pocket, but around 9 millimeter. So we went to the periodontal regenerative surgery. And this is 1 more year result. 1 year later, the pocket was fully recovered by periodontal surgery. And about lower left, so this tooth is only this tooth is different from the other 2 teeth because vitality was plus. So we diagnosed chronic periodontitis. So I'm going to add and explain about the periodontal classification. In 1918, AAP and EFP published a new classification of periodontitis. And they divide a group by a stage and the grade. And the stage is they divided the four groups and thinking about severity and complexity and extent distribution. And for example, this case is the clinical attachment loss is more than 5 millimeters, and the radiographic bone loss was extending to the mid side of the root and beyond the apex. And tooth loss associated periodontitis was more than 5 teeth. And he was need for a comprehensive rehabilitation, and the extent was generalized. So we assigned a stage 4. And about grade. So about the grade, we think about the first middle one is a grade B. But longitudinal data is not sure because it's more than 5 years observation we need. So perfect bone loss is more than 1. I'm going to explain later. And case phenotype was destruction was so-so with a biofilm compared with a biofilm deposit. And he was a non-smoker and no risk about diabetes. But we assigned grade C in this case. And about the perfect bone loss, so it is easily help understanding of us. We put some red ladder in the X-ray and calculate. This is defect was almost apex, so almost 99% per age, 41st years old, equal to 0.4 is more than 1. So grade C. So after the initial treatment, I did regeneration surgery as well. So after remove all the granulation tissue, you can see the three-word bone defect, and we put some biomaterials, mobile bone mineral, and merogenin, and membrane as well this time, and suture. And this was a result of 6 months later. So very the X-ray improving. You can see the improving of the X-ray. And we're going to go to the strategy of Endo-Perio. Endo-Perio region, if you meet Endo-Perio region, please check existing the cause of pulpitis, like a cavity or filling. And if you can find the cause of pulpitis, you may think first primary endodontic and check the vitality. And if the vitality was minus, go to the endodontic treatment. And if you can see no finding of the cause of the pulpitis, and the other teeth was suffering from the perio, you may think the primary periodontal lesion and check the vitality. And this is a little bit complex, but a very important message was a vitality minus and even plus or unclear. You can go to the endodontic treatment first. Because if the primary periodontal lesion, so you may go to the periodontal surgery. If the defect was beyond the apex, you may instrument the apex of the root. So we're gonna go to the endodontic treatment first. And after the endodontic treatment, evaluation after 3 to 6 months, and check the remaining the perio-orientated pocket or not. And if remaining pocket was less than 4 millimeter, non-surgical periodontal treatment. And if the pocket was more than 5 millimeters, the periodontal treatment, surgical periodontal treatment, we go. And why the evaluation after 3 to 6 months? So we can go back to all the papers. Perlmutter research in 4 baboons. Endodontic treatment doesn't know effect to 2.5 months before the periodontal surgery, they said. And De Milander, 60 molars with class 2 furcation defect. They said periodontal tissue won't be affected if it takes more than 6 months after the endodontic treatment. So that's why we wait 3 to 6 months. And about the pulp vitality test, we are doing the multiple test, like a thermal test and electric test and interview as well sometime. And wait, this observation period, if you do the initial periodontal treatment, like a non-surgical periodontal treatment, like a scaling and root training. So during this observation period, if you do not root training, insert the curate very gently. And don't go deeper and only with the motion of scratching up. So one important thing is do very gently. And how is the relationship occlusal trauma and Endo-Perio? So I can share with you another case. This is 49 years old male, and the chief complaint was a lower right gum is sore and I feel like floating. And he was non-smoker and medical and dental history nothing. And we focus on these two, lower right second molar. And you can see the upper and lower anterior teeth. We found clouding, and about the right side. So this patient has anterior coupling loss. So this is a periodontal chart. Is 9 millimeters pocket, deep pocket, like this. And you can see the region along the distal root. And at this time, vital test was weak but positive. So we did initial periodontal treatment. So actually, this is our co-author's Canales case. And after the initial treatment, a little bit improved in a periodontal pocket, about 9 millimeter, but still deep pocket. So we recommended a regeneration periodontal surgery, but the patient denied and quit visiting. So sometimes this kind of things happens. And 4 years later, the patient visited again, but you can see the inflammation and swelling on the same tooth here. And the pocket got worse, about 10 millimeters. And at that time, we did check the vitality, and the result was very weak, but still positive. But compared with 4 years ago X-ray, So you can see the about the distal root. There seems to be a root resorption. So we did root canal treatment soon, and this is root canal filling, and after 3 months, and after 40 months. So the first diagnosis, perio, was not correct. So this is the result. As a result, this case was caused by an endodontic problem we found. Yeah, this is the result. The probing depth was almost improved. And from this case, lesson learned was a vital test shows sometimes false positive, especially in a multi-rooted tooth. So if the pulp vitality seems to be weak or unclear, we may need to perform a root canal treatment. So Langland, the report again, as long as the main canal have not been affected, pulp as a whole keeps vital. And at last, compare with a new classification. So in this world workshop and periodontal news classification involving Endo-Perio parts, and they divided into first two groups: Endo-Perio region with a root damage or without root damage, like a root fracture, cracking, root canal perforation, and external root resorption. And if without root damage, endoperio region in periodontal patients and non-perio patients divided. And each groups they divided grade 1 to 3, and each grade has grade 1 is a narrow deep periodontal pocket in 1-2 surface, and grade 2 wide deep periodontal pocket in 1-2 surface, and grade 3 deep periodontal pockets in a more than 1-2 surface. So maybe this is a very related to the how to do the periodontal surgery, I think. And how is the periodontal treatment goes in the perio? Another case, as a 45 years female, and we're going to focus on the lower left molar. And from the X-ray, you can see the lesion, separated lesion around the apex and pocket. So this is, I think this is right before the getting together, like a true combined lesion. And the periodontal pocket was 7 millimeter in the medial, and the full mass plug score is 42%, and the full mass bleeding score is 25%. And this is what we call a spider net. And we do the assessment in a multiple way, and try to get the this blue part smaller. And in this case, endodontic condition was very poor. So first, we did endodontic treatment like this. And in the microscope view, you can see the granulation tissue in the medial roots. And we did clean up with a ultrasonic scaler in this isthmus site. this. And the longitudinal filling like this. And still you can see the periodontal pocket, periodontal defect. And allow is shows maybe periodontal baseline. And wait for 3 months. You can see the region around the apex was improved, but still a deep pocket. So I can share the treatment time and treatment strategy. So this is originally from Sandro Coltrani, but I modified treatment time for endoperio. So if you diagnose endoperio, and first you may do the endodontic treatment, and you can wait 3 to 6 months. So between this period, so please try to give the motivation to the patient and check the full mouth plug score. And increasing of the plaque means a decreasing of clinical attachment loss gain, clinical attachment level gain. So if the full mouth plaque score is more than 20%, is what we call very dirty. So please try to less than 15%, or if possible, less than 10%. And please check first check the Fromas plaque score and the behavioral factors like smoking and the systematic factors, stress or diabetes. If they are controlled, go to restorative surgery or periodontal regular surgery, non-regeneration. And at last, periodontal regeneration we do. But this endoperio case, maybe so most of the case is very limited to 1 or 2 teeth. So maybe we may go directly to the periodontal regeneration. You may go. And I'm taking a photo. So what blush and what instrument the patient using. And we recommend like this kind of ID blush and calculate the each gap between the teeth. And we give the way which color is suitable for each gap. And in this case, I used this kind of ID blush. And this was the results. So this patient got a Hurmas plaque score less than 10% and breathing score as well. And risk assessment is very good results compared with last assessment. So we did periodontal surgery like this. And today I don't have enough time to explain how to do the incision line or something. So I'm gonna show you some image. And at this time I used bobaribone mineral and merogenin and the suture like this. And 1 month and 3 months and the baseline and the 6 months. So looks a little bit not so calcified, but regeneration will keep occurring sometimes 3 years. So wait for a long time. But pocket is almost 2 millimeters. And the final clan I set. This is 1.5 years after surgery. This is very stable now. So, running object N was today we learned a definition of endoperio and the history of endoperio and the curing rate of endoperio and the classification of endoperio and the strategy of endoperio and at last the strategy of regeneration. And we are uh, we are doing the team Endo-Perio Facebook page. So please join us so we can share the many information about Endo-Perio. And we have a website as well, endoperio.org. So please check it. And at last, this is information for tomorrow. Endo-Perio chat special. So this month, we invite a great clinician, Martina Stefanini from Bologna, and we discuss about regeneration in aesthetic area. So please check and see this program tomorrow. Thank you for the attention.
Thank you very much, Dr. Fumihiko, for the amazing presentation.
Thank you.
So I have received some questions, so I will explain to you. The first question, uh, do endodontic instruments can transport microorganisms to the periapical tissue? If they can, does the damage be severe?
What is endodontic instrument about the? Please one more.
So the question is about if we
Uh-huh.
use the endodontic instrument, sometimes if they are not sterilized, is it can give the microorganism to
Uh-huh.
the periapical tissue?
Yeah, yeah. Of course,
Uh,
all the endodontic
and
instrument needs to be sterilized. Yeah,
yeah,
I think. Uh-huh.
and the participant asks if the
Uh-huh.
microorganism that infected the periapical tissue could give the severe damage on the periapical
Yeah,
or yeah.
if you not sanitized endodontic instrument penetrated through the apex, some microorganisms may go through the apex. But yeah, it's very important to first we need to sterilize completely and so take some take some attention to not to uh, not to get strong pressure using the lemur or yeah endodontic
Okay.
instrument. Yeah.
Uh,
Mm-hmm.
so the next question is
Mm-hmm.
during the observation period that
Mm-hmm.
is 3 until 6 months after the endodontic treatment, while doing scale, the question is it okay if we use ultrasonic
Yeah,
scaler
yeah, yeah,
instead of curette
yeah.
for
I
doing
think it's
scaling or
okay.
plating?
One important thing is if you do the root training, so you can use a hand scaler or ultrasonic scaler as well, but not push strongly. So very use gently, only gently. And if you put the scalar into the pocket and scalar stopped, don't push, don't go down. So gently scratching up. You understand, Claudia? Sorry, I cannot hear your voice.
I'm sorry,
Mhm.
I forgot to unmute. So this is the last
Okay.
question from Put, from Putri. She asks about regarding the endodontic treatment. If we did a failure of endodontic treatment, such as broken instrument or any complication of instrumentation, how can we measure the sterility of root canal so that there will be no persistence of bacteria? So after we failure of the endodontic treatment, how can we measure the sterility of the root canal so that we persistence that there is no bacteria?
Okay. So your question is how do we assess the if the cleaning is completed or not? Thinking about the bacteria.
Yeah,
Okay.
yeah.
So maybe they are used to have some test, a paper point test or something. But recently, I don't do this. So if we do the endodontic treatment, there may be some symptoms like swellings or abscess or pain or something. So if the main symptoms will disappearing, it's a good timing to put the final fillings, put the root canal fillings. You know, so it's let's thinking about the symptoms first. And
So
mhm,
it depends on, yeah. Sorry, doctor, you could continue first.
no problem. You asked, you may ask some broken instrument or something. No.
Yeah, yeah, yeah. I asked that.
So
Yeah. So if
if
they're
the
broken instrument, we need to,
yeah, if
yeah,
the you if you may happen the broken instrument was broken. So first, it is very important to to
yeah.
talk to the patient first, and yeah, and
Oh yeah. Mm.
but if the all the instrument is sterilized completely, it's no problem. But if the some blocking instrument is remaining in the root, but if it's possible, so I think it's better to remove the broken part with a microscope,
Mm.
and maybe by
Okay.
you may refer the specialist, endodontic specialist is better. Yeah.
Oh yeah. Okay. Thank you very much. We have
Hmm.
another question. Is from Tizin Lim. If the vitality of teeth is
Hmm.
positive in endoperio
Hmm.
lesion, do we still need to access to endodontic treatment before assessing periodontal treatment?
Hmm. So it's a very important question. So sometimes if the vitality is plus, we may go to the endodontic treatment. So if one case is you can see the whole mouth, full mouth. Only one tooth is suffering from the endoperio region, and the other teeth are no suffering from the perio. Is caused, maybe caused by an endodontic problem. So we may go to the endodontic treatment, even the vitality was plus. or unclear. Yeah, but almost end of the region is defect was very enormous, and defect is beyond the apex. So if you go to the periodontal surgery, during the surgery you may use ultrasonic scaler or hand scaler or something, and
Yes.
yeah, this instrument touch the apex and injure the nerve. So if the the defect is so deep, and you you diagnose true combined, and you think you may go to the periodontal surgery, we go to the endodontic treatment as well. So it may be both case, primary endo, primary perio,
Yeah.
the endodontic first, endodontic first.
Endodontic first.
Yeah, endodontic first. And one important thing is vitality test.
Yeah.
Is we do multiple times. So
Okay.
before the periodontal initial treatment, and during the initial treatment, after the maybe initial treatment, the multiple times check.
Okay.
Yeah.
Yeah. Thank you very much, Doctor. Yeah. Just
Thank you.
uh, it's very. It's also a reminder for us for every treatment, every step. Maybe for vitality is very important. So we need to the multiple check for make sure it's still vital or not. Okay.
Yeah, yeah, yeah.
Yeah.
So actually, in my university,
Yeah.
in my so when I was a student in my university, I was learned if the vitality plus not endodontic treatment is a vitality minus infection, and all. They're very straight.
Oh yeah.
But actually, it's not, I think.
Okay. Thank you very much for the awesome presentations and explanations. So it looks like we have covered all of our questions.
Hmm.
Thank you very much, Dr. Fumihiko Kimura.
Okay,
And
thank
is
you.
there anything else you want to cover before a wrap up?
Okay. Yeah.
Okay.
So thank you for giving me this kind of great opportunity to speak. Yeah, in all of you,
Yeah.
and hopefully, yeah, this Congress was is success. Yeah,
Okay, thank you very much.
yeah,
Great, thank you
success rate.
everyone. We appreciate Dr. Fumihiko Kimura for sparing his previous time to explain and sharing their
Thank you.
knowledge to us. And thank you very much for all of you who already attend this IADS virtual webinars. Thanks again for joining us today, and we will see you next time. Thank
Okay,
you.
thank you. So I'm going to share one laugh from Japan.
Oh yeah. It's- thank you.
Thank you.